Hi, everybody. You are listening to the Medea podcast series. Medea Medical Education Academy is a global medical education provider dedicated to designing, delivering, and evaluating medical education programs worldwide. Today, we will be speaking with Amir Lerman, an endowed named Barbara Lips Professor of Medicine and a consultant in the Department of Cardiovascular Medicine at the Mayo Clinic Graduate School of Medicine. After listening to this podcast, participants will be able to be familiar with the new guidance on positioning of beta blockers in cardiovascular disease management and be informed about current recommended treatments for patients with coronary artery disease. This podcast is part of the continuing medical education program entitled Cardiovascular Disorders and Hypertension 2025 From Guidelines to Management, targeting clinicians, including cardiologists, internists, and general practitioners, nurse practitioners, and other healthcare professionals who manage patients with cardiovascular disease and hypertension.
Thank you, everyone, and thank you very much for the opportunity. My name is Amir Lerman. I'm a professor of medicine in the Department of Cardiovascular Disease at the Mayo Clinic in Rochester, Minnesota. And I'm a cardiologist and also intervention cardiologist. I'm also serving as a director of the Mayo Clinic Cardiovascular Research Center and part of the executive committee of the Department of Cardiovascular Disease. My area of interest is researching coronary artery disease using new technology such as artificial intelligence and new devices for the treatment of coronary artery disease. Also interest in vascular biology and the mechanism by which vascular biology and pathology contribute to coronary artery disease.
Coronary artery disease treatment involves a multifactorial approach. What are they?
Very good question. So first of all, I think we need to lay the background that coronary disease is a sort of a chronic progressive condition that started at early age. Even autopsy studies from young people that die in the war show already evidence of coronary disease. So it's a progressive process that involves also inflammation and plaque building in the vascular wall. Over time, some of these plaques become more vulnerable and rupture and create thrombus and potentially leading to acute coronary syndrome and myocardial infarction. So it's important to know that although this is a chronic and a diffuse disease, the events that occur are usually local in the vascular wall. We also need to remember that coronary disease is not about only the large vessels of the arteries of the coronary, but also involve the small vessels or the microvascular and the vascular function such as endothelial function that is considered part of the regulation of blood flow to the myocardium. So with this background, I think the first levels of the multifactorial approach is like everything in medicine, what you need to do is, first of all, talk to the patient to understand if the patient has symptoms, if the patient have any compromise of their quality of life, if they have any chest pain or angina or equivalent. And that's very important to determine what should be the next step. And then we move to the physical examination, which helps us to reveal if there is any other associated condition that may contribute to the patient status and symptoms. With this in mind, we need to, again, work along the timeline of the patient to determine the multifactorial approach to the disease. So if the patient is presenting with acute chest pain and have acute coronary syndrome myocardial infarction, the usually treatment for that or the approach is proceed with coronary angiography and potential revascularization, whether with stent or bypass surgery. If the patient presented with a progressive episode of chest pain, which are not acute coronary syndrome, then the next step is to evaluation to serve the link between the symptoms and cardiac functions, such as exercise tests, treadmill, or with and without imaging. Based on that, we can determine if the symptoms of the patient are related to any underlying myocardial ischemia, which will determine the treatment, whether medical therapy or to proceed with more invasive tests. We also need to consider the use of imaging in the multifactorial approach to the treatment, which is again use a non-invasive imaging such as echocardiography or nuclear tests or MRI, which can help us determine the function of the heart and the link between the disease to the heart. Then we go to the next level, is to determine the goal of our treatment. So if the patient is in the early stage of the disease and does not have any symptoms or mild symptoms, our goal is to overcome the symptoms, but particularly attenuate the disease process and what we call a primary prevention, and try to prevent the first event of myocardial infarction. This is determined by the treatment of risk factor that we're going to discuss later. But if the patient has symptoms, there is a treatment for angina, such as nitrate and potassium channel blocker, to overcome the disease. Then we need to remember other part where the goal is to reduce cardiovascular event. What are we trying to do with the treatment? For instance, we need to remember that treatment with revascularization such as stent do not reduce cardiac event in this patient, with chest pain. So this has to be reserved to patients that do not respond to medical therapy or patients that are presenting with acute coronary syndrome. If the patient proceeds to have a coronary angiogram or visualization of the arteries, if it can be done non-invasively by CT or by invasive angiogram, that can determine if the patient have underlying obstructive or non-obstructive disease. If the patient have non-obstructive disease and still have symptoms, we need to consider the evaluation of endothelial function and microvascular function. If the patient have obstructive disease, it depends on the extent and of the obstruction and the link to symptoms, and then we'll determine if the treatment is medical therapy or proceed to invasive therapies such as stent or bypass surgery. If the patient has no symptoms, then cardiac evaluation usually is not necessary unless there is a suspicion that the patient have significant family history or abundance of cardiovascular risk factors. So the approach to patient with coronary disease involves multiple factors of physical exam, talking to the patient, imaging modality, and determine if there are symptoms and the link between symptoms and the presence of underlying coronary disease, large vessels or small vessels.
Where do the guidelines place beta blockers for the treatment of coronary artery disease?
Great. So this is currently a very relevant and controversial issue. So if we look at the guidelines themselves, beta blockers are the first line of agent for symptoms relief in patients with stable angina. So the patient have symptoms, and beta blocker is one of the first line of treatment of angina by reducing the heart rate and also improving efficiency. Now, primary prevention in stable coronary disease without previously heart attack is not recommended to give beta blocker. Where the guidelines become a little bit controversial recently is the guidelines call for use of beta blocker for 3 years after myocardial infarction. That has been debated now, and currently the recommendation is to give beta blockers to patients following acute myocardial infarction only for a year, and if they have decrease in LV function. And the reason for this controversy is because the guidelines for the use of beta blocker following myocardial infarction came prior to the revascularization and perfusion. So this treatment was in patients that did not achieve full revascularization and reperfusion of their obstruction. So currently, we give beta blockers to individuals who have post-myocardial infarction for a year. There's also debate about that if they have normal ejection fraction or normal function. But for sure, if they have post-myocardial infarction and ejection fraction less than 50%, beta blockers are recommended for a year. If the patient have chest pain, it's recommended as a first line. And if the patient have heart failure from ischemia or heart failure secondary to ischemic cardiomyopathy, beta blocker are also recommended in this kind of situation. But again, this is now a subject of debate and future studies.
What are the risk factors for coronary artery disease?
So the risk factors are the background and the environment that are controlling the presence and the progression of coronary artery disease. When you talk about risk factors, it has to be individualized, but you need to divide the risk factors to non-modifiable risk factor, I mean risk factor that exist but you cannot change them, the modifiable risk factor, the risk factor that you can actually change with treatment, and a new emerging novel risk factors. So let me talk about the non-modifiable risk factors. As I said earlier, coronary disease is a progressive disease along the timeline. So age is a non-modifiable risk factor. You cannot change your age, your chronological age. You may be able to change your biological age, but not your chronological age. So age is a risk factor for men about 45 and for women about 55 years old. Determinant of the sex also have a risk factor. Male have higher risk of coronary disease than female, and female postmenopausal have increased risk of coronary disease similar almost to men. A strong family history of premature coronary disease is again one of the major risk factors and non-modifiable. You need to ask the patient about the history of myocardial infarction in their sibling, parents, grandparents, and brothers and sisters to determine if the patient have a family history of coronary disease. And then there are less common ones, which are genetic factor that has to be, sometimes there is genetic factor that contribute to the progression of coronary disease, like familial hypercholesterolemia. And recently there is a call for the role of epigenetic in the role of coronary disease. That means you don't only need the genetic, but also the expression of the gene. And recent non-modifiable risk factor is called CHIP, which is emerging as a risk factor. Then we move to the modifiable risk factor, which usually serve the majority of the risk factor for coronary disease. So the first one is hyperlipidemia. It can be treated high LDL, low HDL, and high triglyceride. So high LDL, first line of treatment is statin. If there is side effect or resistance, you can move to the adding something like ezetimibe. And if this is not helpful, then you can resort to the new injectable medication like PCSK9 inhibitors or low messenger RNA to treat hyperlipidemia. This is a major risk factor. Hypertension, blood pressure control, is a major risk factor for coronary disease and needs to be treated for the prevention of ischemic heart disease and stroke. Diabetes, measurement of hemoglobin A1C and glucose, and family history of diabetes is a major risk factor for coronary disease. And another one that is modifiable is smoking. Smoking is one of the major risk factors for coronary disease, and one of the reasons for the reduction of myocardial infarction rate in coronary disease in the Western society is the reduction of smoking. Obesity, especially visceral obesity, is linked to metabolic syndrome and increased risk of coronary disease, also a modifiable risk factor currently addressed aggressively by the SGLT2 inhibitor and GLP agonist. Sedentary lifestyle and unhealthy diet are modifiable risk factor. We need to encourage our patient to engage in regular exercise and review with them their diet and recommend healthy diet, less of saturated fat, more vegetables and fruit, less sugar for them. Emerging risk factor recently that have been addressed are the psychological stress. This has become very apparent currently. You have elderly patient or adult patient with social isolation. They don't have any connection to friends and family and create a psychological stress. This needs to be addressed, and we need to resort and ask the patient specifically if they are exposed to social isolation and psychological stress. This is also modifiable. Other general influences that can be linked to dental workup and rehabilitation and gout and other systemic inflammatory disease that can contribute to progression of coronary disease. Then there is the emerging and novel risk factors. So when you look about family history, one of the common thread you can find is elevated of lipoprotein little a, which is considered a risk for coronary disease. This is still in investigation because it's known that if you have elevated LP little a, it runs in the family and it is associated with more progressive coronary disease. What is not known currently is what's the consequences of reducing LP little a that currently do not have a specific approved treatment. So this is still an area of investigation. Elevated CRP, since coronary disease have a major inflammatory component, This is termed as the inflammatory reserve or index, which you can have patients with normal cholesterol but high CRP still at risk. So we need to investigate if there is any source of inflammation. We know that aggressive treatment with lipid lowering and statin and the new medication can reduce inflammatory burden and reduce the progression and the event in coronary disease. Coronary calcification used to be a very popular to detect by CT without contrast. Coronary calcification is a marker of presence of coronary disease. If you have no calcification in the coronary, you can guarantee that you are in several studies that you're going to be event-free for the next 2 or 3 years. However, coronary calcification is a marker for coronary disease. It's not modifiable. There is no treatment for that, but it can serve for you as an index that the patient have presence of coronary artery disease. Other one are homocysteine levels. Currently are done in several places. Very high homocysteine levels can serve as an index for progression of coronary disease. And recently, we become aware of environmental risk factors such as air pollution exposure and exposure to noise can be associated with the progression and more event from coronary artery disease. So in summary, there are modifiable risk factors, non-modifiable risk factors, and novel risk factors that we need to address when we evaluate patients with suspicion of coronary artery disease.
What take-home messages do we have at the end of this podcast?
Heart disease, and specifically coronary disease, is still the leading cause of morbidity and mortality worldwide, and specifically in the Western Hemisphere. Coronary disease potentially is progressive, but we have now tools to reduce the acceleration and the progression of coronary disease. Patient needs to be evaluated. Specific emphasis needs to be placed on modifiable and reduction of risk factors, starting with early age, and the treatment of these risk factors if can be done. The link between symptoms and underlying coronary disease is necessary prior to starting any mode of treatment and prior to committing the patient to more invasive revascularization such as stent and bypass surgery.
Thank you for listening to this Medea podcast. For more information about our continuing medical education programs, please visit our website at medeaacademy.com.